Well, g'day everyone. Good morning and welcome to the final symposium in our 2020 Symposium Series. Before we start, I'd like to do an acknowledgement. I'd like to acknowledge the traditional owners of all of the different Indigenous people who may be with us today. I also pay my respects to elders past, present and emerging. And just before we get on to it, I'll just sort of do some housekeeping. We have two speakers today, Louise Bullen and Liz Dale. And to keep the day moving, or the morning, we will take questions after both talks, if that's okay. If you have any questions along the way, please click on the Q&A, the question and answering section on your screen. Unfortunately, Liz can't join us after her presentation for the Q&A, but she'll be happy to answer these by email. So any questions for Liz, can you write them in the Q&A panel and give your email and we'll get back to you. Our team will dismiss similar questions to make it easier. Any technical issues that you might have whilst this symposium's going, please comment in the Q&A section and Talia or Monica will help. This webinar will be recorded and for people who could not join us, and we'll tell you where you can get it at the end. Thanks a lot. So I'll hand you over to Talia Reynolds, who's the Admin and Research Officer for the Centre for Research and Excellence in Indigenous Health and Alcohol, to introduce today's speakers. So I hand over to Talia.
Thanks, Scott. Morning, everyone. First up, we'll have Liz presenting. She's a Worimi woman enrolled in a PhD at the University of Wollongong. She's also a psychologist. Liz has over 15 years experience working in non-government and clinical settings. This includes in youth and adult homelessness, addiction, eating disorders, and intergenerational trauma. Then we'll have Lynette. Lynette is a Wiradjuri woman undertaking a rural research capacity building program through New South Wales Health. She has worked in drug and alcohol for nearly 25 years. Lynette is employed at the Involuntary Drug and Alcohol Treatment as a senior drug and alcohol clinician. Thanks, Scott.
Thanks, Talia. Baran Maruminya, Euro Woblin, Baraba Yitilis, Dangbang Worimi Galban. Hi everyone, my name is Liz and I am a Worimi woman, and today I'm going to be speaking to you about a study that was part of my PhD program called A Multi-Methods Yarn about Smart Recovery, First Insights from Australian Aboriginal Facilitators and Group Members. Before I begin, I'd like to acknowledge that I'm giving this presentation today on Yuin Country, which is where I was born and raised and working, and I'm raising my own family. I'd like to acknowledge Creator God, elders past, present, and recognise those who are emerging of the Yuin Nation, of the traditional lands that you're watching this webinar on today, and to the countries represented by the participants involved in the study. It's also appropriate to acknowledge that prior to this study, there were an amazing group of Aboriginal facilitators already advocating for a more culturally meaningful Smart Recovery program. A lot of this earlier work was done by Auntie Sylvia Campbell and Uncle Jimmy Bell, who are based here in Wollongong running Koori Smart, as well as a handful of other Aboriginal facilitators in other parts of the country who have altogether allowed me to build on their work. I also just want to acknowledge my talented team of supervisors, my co-authors, to Dr. Angela Argent and Josette Freeman from Smart Recovery, and to all of the Centre of Research Excellence, my staff, fellow students and trainees, who've all helped make this work possible. Just a quick disclaimer that I am a member of the Smart Recovery Research and Advisory Committee. However, I was not a member at the time that this study was completed, so it's not in any way influenced the research. So just a brief background for Smart Recovery. It's one of the world's leading mutual support group programs that's freely available for anyone seeking to recover from harmful levels of substance use or problematic behaviours of addiction like gambling. It was founded in the United States of America in 1994 and is now delivered in over 24 different international countries. It began operating in Australia in 2004. Smart Recovery is entirely evidence-based. It draws largely upon cognitive behavioural therapy and motivational interviewing to encourage people to make self-empowered behaviour change. The program has a 4-point approach to recovery, which is to build motivation, cope with urges, problem solve, and attain a lifestyle balance. These are supported by program activities such as goal setting, cost-benefit analysis, role plays, and change plans. So the reason for the study. So prior to the research I'm presenting today, we conducted a PRISMA-informed systematic literature review to retrieve all available evidence of addiction recovery mutual support groups like Smart Recovery for the Indigenous peoples of Australia, New Zealand, Canada, the United States of Hawaii, and America. Using an open-ended date range and searching both peer and grey literature databases, we found a total of 4 studies that had all been published between 2001 and 2006. These 4 studies only involved the Indigenous peoples of America and the mutual support group Alcoholics Anonymous. And this was only featured because it was connected to a primary research aim, which was to explore the kinds of addiction recovery services that Indigenous American people were accessing. None of the articles mentioned Smart Recovery or had asked or at least reported on asking Indigenous peoples for their perceptions of or outcomes associated with their mutual support group attendance. We'd basically identified a major gap in the literature. The lack of an Indigenous voice suggested that mainstream mutual support groups like Smart Recovery have not been designed with the needs and preferences of Indigenous peoples at the forefront. So the logical next step was to fill this gap with the Indigenous voice. So we conducted an Indigenous lens multi-method study that was committed to privileging Indigenous knowledge holders and prioritising Indigenous knowledges. Some of the actions taken to honour the Indigenous voices in our study were ensuring that the data was collected relationally and respectfully, and the final research report was written up in collaboration with participants. I also chose to listen to each participant's audio recorded research topic yarn while reading through and coding their paper copy transcripts. This meant that their unique emotions and prosodies helped guide me through the knowledge production phase. I also analysed each of the 3 groups' data sets separately, i.e. there were interviews, surveys and observational data specific to each group, so that I could preserve and appreciate each group's unique storyline before it was amalgamated into a final data pool. Data was collected by synthesising Indigenous qualitative research methods with Western quantitative research methods. Research topic and social yarning were used to explore which aspects of the program participants liked and found helpful. Participant surveys were used to collect demographic information and to identify which of the program activities participants were liked and were using. I also observed 3 Aboriginal-led Smart Recovery groups and administered an 18-item Smart Recovery program adherence rating checklist that had been designed in collaboration with Smart Recovery specifically for this study. The checklist was helped us to characterise the Aboriginal-led groups by allowing us to detect and make notes about any omissions, adaptations or supplementations to the original program that were visible. All data were collected concurrently and qualitative data were analysed using grounded theory. So our participants were 10 Aboriginal facilitators, 13 Aboriginal and Torres Strait Islander group members, and 3 Aboriginal-led groups, 1 in New South Wales and 2 in South Australia. Our participants represented 5 different communities in 2 Australian states, and these were Yuin, Gadigal and Bundjalung, and Nunga and Ghana in South Australia. The facilitators were mostly male with a mean age of 50.5 years. In contrast, our group members were mostly female with a mean age of 34.5 years. All but one member was attending voluntarily, and the most common reasons for attending were drug use, followed by alcohol and drug use, then disordered eating. All groups were running weekly, and the average, oh sorry, I skipped a, no. All groups were running weekly, and the length of the group were 4 hours, which comprised 1 hour of the official meeting time, then 3 hours of social yarning before and after groups, which also include sharing a meal together. All groups were for ages 16 and up. One group was for females only, and there was a male only equivalent of this group, which I didn't observe, obviously, for cultural reasons. One group welcomed both Aboriginal and non-Aboriginal people, and all groups welcomed partners, family members, or other significant support people. 2 groups were hosted within an Aboriginal community-controlled health organisation, and one was within a state government-funded health service. All groups provided members with transport to and from the groups, food, drink, and writing materials. They regularly invited guest speakers, and the groups that were hosted within an Aboriginal community-controlled health organisation were often co-facilitated with other health and wellbeing staff belonging to that service. So what did our participants say was good about Smart Recovery? Well, the most popular reason for liking Smart Recovery was the concept. Everyone said it provided the community with a reason to set aside a space and a time to have a specific recovery-focused yarn. Group members said what they liked was helping each other to problem solve, setting and achieving weekly goals, and being able to form new friendships to replace the social connections that were lost when they gave up drugs and alcohol. These relationships were also said to be really important to create a sense of accountability, which motivated them to attend regularly, and even if they'd made slip-ups in their recovery journey. Most of the group members also saw that coming to groups was role modelling positive health-seeking behaviours within their communities, particularly to the younger generations. And for the groups that were hosted within an Aboriginal community-controlled health organisation, there were additional benefits, such as having access to brokerage and to wraparound support services, like doctors, one-on-one counselling, and family support workers. What did our participants say was not so good? Well, the facilitators felt that the program and the way they were trained to run the program was too formal and strict. All facilitators had chosen to relax the structured meeting format and were running groups like a yarning circle. This slide shows a Smart Recovery adherence rating checklist. And as you can see, and the overall score that was achieved by each group. As you can see, the 2 groups in South Australia scored 44%, which indicates a low program adherence rating. And the New South Wales group scored 55%, which indicates a moderate level of program adherence. The grey boxes show the 5 program components that were common across groups. And when you look at these, you can see that these are akin to yarning circle protocols, in that there's a member check-in, there's the reciprocal group discussion time, and a formal member checkout. All participants then said that they felt that the program needed tweaking. Facilitators found that the training lacked content that would educate upcoming facilitators about how Aboriginal people experience addictions and approach addiction recovery. They all felt that the language was too clinical and that the marketing and branding of Smart Recovery was unappealing for Aboriginal peoples. Both facilitators and group members also said that they needed and wanted Aboriginal specific psychoeducational information and culture-focused program materials. The major outcome of our study was the creation of a list of 4 key areas of program improvements offered explicitly by Indigenous Australians as to ways that the Smart Recovery program could enhance its cultural utility. The 4 key areas were to integrate Aboriginal perspectives into facilitator training, to incorporate Aboriginal specific program materials, to improve community engagement, marketing and networking, and establish an Aboriginal specific program. So in summary, this study offers the first insights from Indigenous Australians about the suitability and helpfulness of smart recovery. It has shown that although there are some culturally suitable aspects of the program, there are other areas related to the program's marketing, content and delivery style that could be adapted to enhance its cultural utility for Indigenous Australians. Future research is now needed to grow this body of knowledge by obtaining the voices from more diverse Indigenous community groups, both nationally and internationally, and more research is needed to measure the health outcomes associated with attendance. Thank you for listening.
Thanks, Liz. It's amazing, and obviously anyone's got any questions, can they sort of, as I said, Liz can't attend the Q&A, so can you put your questions into the Q&A section? It's pretty amazing that, you know, mutual support groups have been around for a long time, but this is the first time that there's actually been some research from an Indigenous perspective. But anyway, we're moving on. We'll now take some, like I said, we'll wait until the end. We're basically, our next speaker is Lynette Bullen, and she'll be talking to us as well. So can we ask Lynette to share her screen? Thanks, Lynette.
Thanks very much, Scott, and thank you for allowing me to present today at the symposium. So, good morning, everybody. My name is Lynette Bullen, and I'm a Wiradjuri woman. I would like to acknowledge the traditional custodians on the land that we're all meeting on today. Elders, both past, present, and emerging. I'd also like to acknowledge any Aboriginal or Torres Strait Islander people here with us today online, as well as our non-Indigenous colleagues. I'd like to thank the following people and organisations for their support and guidance with my research over the past 18 months. Thank you. Today, I'll be presenting my research study and early findings on what factors influence drug and alcohol clinicians when referring Aboriginal clients to involuntary drug and alcohol treatment in New South Wales. Around the world, there are different models of involuntary treatment for drug and alcohol. Some of these programs are invoked by the courts. For example, community-based treatment orders, and here in New South Wales, the Merit program, where the magistrates revert people into drug and alcohol treatment. In injustice-invoked programs, a person's criminal behaviour, for example, break and enter and drug supply, is the catalyst for being sent into treatment. Another model of involuntary care is health invoked. This is where people are ordered to go into treatment as a life-saving measure or last resort. In New South Wales, involuntary drug and alcohol treatment programs have been operating in New South Wales for over 100 years. This was part of the old Inebriates Act. Under the new Act, in September 2012, 2 involuntary drug and alcohol treatment programs opened in New South Wales. There are 8 beds here at the Orange Health Service, Bloomfield campus, where I work, and 4 beds at the Herbert Street Clinic at Royal North Shore Hospital in Sydney. To get into an involuntary unit, a patient needs to meet all 4 essential criteria. The first is that the client must have a severe substance dependency. Secondly, treatment and control of the person is necessary to protect them from serious harm. Thirdly, there is likely to benefit from treatment, but the client's refused treatment to date. And finally, there are no other least restricted options available for the person. An involuntary treatment program consists of a medically safe detox for each individual who's admitted. And the IDAT team consists of an addiction medicine specialist, medical officers, nurses, social workers, drug and alcohol clinicians like me, OT, psychologists, pharmacists, physiotherapists, and dietitian. Functional and cognitive assessments are conducted by our OT and psychologist. Other assessments can be organised, such as brain MRIs, bone scans, and even the commencement of Hep C treatment. Group programs are also on offer. Then, before discharge, family and/or case management meetings are offered to organise discharge planning. Everyone needs to stay for 28 days if the dependency certificate is granted. But this can be extended, again with the magistrate's approval, for a further 56 days, but only if there is shown cognitive impairment. Since the repeal of the original Inebriates Act, fewer Aboriginal people have been referred and admitted into involuntary treatment here in Orange. You can see here in the top table an internal audit of clients admitted into Bloomfield campus under the old Inebriates Act. This was conducted by myself and Dr. Lee Nixon, the former medical director of the Orange IDAT unit. Data shows referrals between 2008 and 2012 that there was twice as many non-Indigenous people referred to Orange than Aboriginal people, so 21 versus 10. The second table uses data between 2012 and 2015. When the new Act came in, the numbers of non-Aboriginal people being referred to IDAT was very much increased. In fact, the rate of non-Aboriginal people being referred to involuntary treatment went up 7-fold. But the referral rates of Aboriginal people stayed around about the same, 13 versus 10. At the same time, there was an increase in alcohol attributable hospitalisations experienced by Aboriginal people in New South Wales compared to their non-Indigenous counterparts, as reported by New South Wales Health. So while we see Aboriginal people experiencing more hospitalisations related to their drinking, this has not resulted in increased referrals for involuntary care. So the aim of my research is to explore the barriers and enablers to Aboriginal clients being referred to involuntary drug and alcohol treatment in New South Wales. Why is that? At least in the Orange unit, we were seeing less differences in referral by Aboriginal status. So how did we do this study? We conducted semi-structured interviews with clinicians who had referred a client to IDAT between 2016 and 2018. This time period was chosen as New South Wales Health had commissioned NDARC to do an evaluation of their involuntary drug and alcohol treatment programs based on analysis of client data. For this study, interviews were conducted by an independent researcher who does not work in IDAT. Thank you, Dr. Alice Munro. And clinicians were invited from 11 LHDs in New South Wales, from urban through to remote sites. Clinicians, to ensure cultural sensitivity, an advisory group was established to provide guidance and governance to this study. And ethical approval was granted by the AHNMRC and New South Wales Health. The semi-structured interviews asked 15 questions that were organised into 4 categories. About the clinician and their experience working in DNA, each clinician's thoughts on referring of Aboriginal clients to involuntary care, including the referral process, what clients see as the advantages and disadvantages of involuntary treatment for Aboriginal people, and what supports the clinician felt would assist with referrals, admissions, discharges for an Aboriginal person. An inductive thematic approach is being used to explore our research question. Preliminary analysis has commenced just last week. Because I also work in IDAT, we have engaged a second independent researcher to also conduct the analysis. Thank you, Catherine. Then Catherine and I and my supervisors will meet to agree on the final results from the analysis. Interviews are complete. They took around about 1 hour each and were conducted through New South Wales video conferencing. This was useful as people were from all over New South Wales, but also due to COVID restrictions. We spoke to 12 clinicians across rural to urban New South Wales. There were 2 men and 10 women. This reflects the higher number of women in this sector. Collectively, the interviewees had 170 years of experience as clinicians in the drug and alcohol field and mental health. There were 3 emerging ideas from the 8 interviews analysed so far, representing the opinions of 2 males and 6 females. The 3 of the emerging themes from my analysis are the complex nature of clients' presentations, the benefits of an admission, and some of the barriers to referring. All clinicians spoke about the Aboriginal patients presenting with multiple complex health and psychosocial issues. Health issues included end-stage liver failure, dental problems, unmanaged diabetes, cardiac issues, decreased mobility, and cognitive impairment. The psychosocial issues included homelessness, emotional trauma, domestic violence, past incarceration, and disengagement from family and friends. For example, one clinician said, IDAT was really life-preserving at that point. We tried every other intervention and nothing had worked. We needed to save this person's life. We needed to have them taken somewhere, really, essentially against their will, to get some kind of medical treatment that may prolong or sustain life. Clinicians also spoke about the benefits of an admission, especially given their complex presentations. Comprehensive assessments conducted as part of an IDAT stay were seen as beneficial for providing the evidence to set up access to wraparound services when the person's discharged. These assessments can also be used to gain access to services such as the National Disability Insurance Scheme, aged care assessments, guardianship and financial management orders. One clinician commented, it's more about them doing a holistic, comprehensive health assessment so that they can try and pick up certain areas that the person might need help for. Another clinician said that, in my experience, the team, they are very good at dealing with complex medical, social, psychological, and psychiatric problems. So people with complex needs, that's rare to find a service that can actually do that in a very intense way. That would be a great advantage of being admitted into an IDAT service. Many clinicians reported barriers to referring Aboriginal people to involuntary care. One was the distance from family. Only having 2 involuntary units in New South Wales makes it difficult for the individual and their families. One clinician said, I had a lot of Aboriginal families saying, well, we need to do something. We need to lock them up. So that created the conversation around what involuntary treatment looked like. Most families, once it was unpacked and realised that the sites were so far away, reneged and said, okay, what can we do instead? The second barrier to referring is that IDAT was seen as taking away people's choice about seeking help for their drinking and drug use. One clinician said, the last thing we want to do is superimpose ideas that will bring back traumatic memories for people of white fellas just making decisions for me, whether I like it or not. If we do nothing, the person is probably going to die. If we do something, well, this could be seen this could be misinterpreted as just another service going to take away control over me, and make me do something that I don't want to do. The third barrier of referring is that only having 2 units means that for many people, they need to go off country to get involuntary care, with one clinician commenting, "One of the concerns I have with referring some of the patients, Aboriginal patients, was taking them off country. If you take into consideration possibly their traumatic history as well, if they've been moved off country like the stolen generation, then you need to tread a little differently." So what does that mean? Overall, clinicians see an admission into involuntary care as beneficial to the comprehensive assessments provided, which can help with recommendations for future planning. However, some concerns were raised with the lack of services to support clients once they are back in their community. But looking at the broader research landscape, much more research is needed. It is not clear the outcomes of involuntary programs over time for Aboriginal people. I saw that there was no Australian studies that asked staff for feedback on the programs provided. So this study seems a logical place to start and easier than recruiting and following up IDAP patients. So where to from here with my study? From here, we'll finalise the analysis, provide feedback to clinicians who took part and to both IDAP units, and then we'll write up the findings for publication. Thank you very much.
Thanks, Lynette. We'll now take some questions. So we have about 20 minutes for questions. So is anyone, I've got a few. Thanks, Lynette. So basically the question is asking that this is an involuntary treatment program is triggered by health needs, not by the justice system. Is that right? Because it seems very different to the Northern Territory involuntary treatment system.
Scott, thank you very much for that question. And it is very, very different to the Northern Territory alcohol mandatory treatment program, which is now has been evoked. We are focusing on health. This is not a justice invoked system. The Inebriates Act in the past here in New South Wales, it was a justice invoked program. But with this one, we're looking at the health needs that the individuals actually can benefit from an admission to IDAT. We look at most of the people that come in here, they've had stays in hospital, you know, maybe 90 times in the last 3 months prior to admission. So we are looking at this as a health invoked model of care for our people. Thank you, Scott.
Yeah, another one. What are your thoughts of the concerns that involuntary treatment may re-traumatise Aboriginal clients, and do you see evidence that it occurs?
Look, some people find it difficult, and I think that's both our Aboriginal people as well as our non-Indigenous people, but certainly for Aboriginal people, yes, it does bring up some issues for them. One of the things that we have here in Orange is as soon as someone comes into our unit, I welcome them into our unit. The engagement process, I think, is so important, but also, maybe I need to take a step back, is that our referrers also try and work with them prior to the person coming into IDAT. So I see that as a very, very important. Again, when they're here in our unit, we'll actually look at, you know, how can we make your stay a little bit more comfortable? So it might mean having a little bit more time out, even though we're involuntary. Sometimes I think we allow more freedom than what people actually get in you know, voluntary treatment programs. So it might mean catching up with family if they're close by. It may mean going for a walk around the beautiful gardens here at Bloomfield. calling their families a little bit more regularly. So we try and engage family and to try and reduce some of that trauma of coming in here to our program. Yeah, thank you, Scott.
Yep. Once a client has returned home after entering the IDAP program, is information provided to families on how to best support the individual?
Sometimes yes, and sometimes if there's, we can't do that if the families aren't around the person. We certainly work very, very closely with the referring services. So we do try and have case planning meetings prior. We may invite family members to either dial in via phone, or now I think everyone's getting so used to Zoom that they're feeling more comfortable, being able to do a video link up with us, so that we can talk to them about the support of having perhaps a alcohol-free in a home for when they go back to. However, some of the analysis, what I'm reading with the interviews is that a lot of the clinicians are saying that there's not a lot of support out there in our rural and remote areas. And which is really hard, especially if we've done all the assessments. This is what the person really needs to support them back home in community. So hopefully there can be more open discussion when I provide this information to the Ministry of Health, that we can look at perhaps how are we going to engage other services out in these smaller communities. One, it's interesting, I think it really sits well with Liz's research that one of the clinicians was saying when she was interviewed that smart recovery, they want people to go to smart recovery, but it just needs to be tweaked a little bit more for that community. So it's more identified and supportive of the people that are living in that community. Yeah.
In your opinion, why do you think there's not more peer workers than those with lived experience?
I actually think funding, because we can't just have people coming in voluntary. We need to honour those people that have had past experiences to be a valuable member of the team. And so at the moment, there's not a lot of funding for that. We do have peer workers in our mental health services here in Orange, and I think we need to maybe value their input a lot more and open up our doors for more peer workers to come in to support them. I know Herbert Street, they actually have a lot of, they do have a peer worker that's working down there in Herbert Street. And the person obviously went through Herbert Street and has, and is close by so that that person can go in and work. But here in Orange, there's not a lot of people that are able to come in and work with our clients that have been through the program themselves, because our clients could have come from Tweed Heads down far as Albury, so getting them to come back it's not possible. We do invite our past clients here in Orange to come back for a barbecue, which I actually do think is valuable, because then they can talk to them about their own experiences while they were in the unit.
Sorry to be continually putting you on the spot. You probably think,
oh, that's okay. If I don't know how to answer it, I'll just throw it over to someone else.
But because unfortunately Liz couldn't be here, that's why you're getting all the questions. But anyway, in the Northern Territory system, people might be charged for absconding from involuntary treatment. Is this what happens in New South Wales?
Oh no. If someone absconds from our program, and that has occurred, usually they don't go very far. And often here, the experience that we have had here in Orange is that they will be brought back in because they may have gone out, had quite a bit to drink, and so often end up back in emergency care, and then they just come back into us. If someone often family members have brought someone back in, but they're not going to be charged with a criminal offence. Coming into IDA is not a criminal, they're not coming in because of crimes, they're coming in because of health. We want to support them and help them and guide them into making more, better choices. Yeah, but certainly not charged. And I do know down in the Northern Territory, they did take that being charged out of the Act, sort of half, I think, earlier on in that program.
Yeah, are you intending to do future work to find out from Indigenous people potential ways of overcoming barriers similar to Liz's approach?
That's a really good question, Scott. I would really like to continue on looking at this more because I see people coming into IDA and I can see the change that occurs over a 1, 2 or 3 month stay with us. So I'd really like to talk to our Indigenous clients coming into our unit, what they actually think about coming in. How do they feel about it? The interviews that we conducted, they were all non-Indigenous. So we're getting their thoughts coming through. I'd also like to ask the thoughts of our patients, the family members, and other Aboriginal organisations and Aboriginal drug and alcohol workers. What are their thoughts on it?
Yeah, just one question, basically saying thanks, Liz and Lynette. You're both doing groundbreaking research that is much needed, both smart recovery and involuntary treatment. Do you think there is a case for Aboriginal specific services, or is it better to have mixed groups?
I think rehabs, it's not one size fit all with rehabs. Having worked in the area for a long time, I think both can offer good things to their participants in their program. What I'd like to see is our units here, whether or not it's more programs throughout New South Wales, if that could happen, so people can stay close by. But a lot of times people, even going off country, even going to a specific Aboriginal rehab program, sometimes they still have to go off country to attend those programs. I'd like to make sure that all our programs are culturally sensitive and that all participants feel safe in going to those programs. Thanks.
Yeah, this is a bit of a long one, but anyway, thanks. Referring clients, there can mean a chance at stabilisation. Basically, they found it harder for hospital admissions can be a good site to refer from in terms of organising transport. But hospital clinicians don't seem to be aware of options, and when it is raised as an option, decline to refer. Did you find that in your research, because of the logistics of obviously transporting people from wherever to your service?
Yeah, Scott, look, in some of the feedback that I'm starting to read, we are noticing that transport is an issue. So because the clients that are coming into our program are extremely unwell and, they're prone to perhaps withdrawal seizures, we want to transfer them as quick as we can to our program. We do sometimes need to have the patient clinically stable before they transport, especially if it's distance. But the New South Wales Ministry of Health have actually provided funding to every LHD to assist with the transport costs of bringing someone up to an IDAP program because they know how far the travel is. So many of our clients that come to Orange are often flown here through Wingaway or air ambulance.
Yeah.
So it is a big thing. The travel is quite significant. Yeah.
So Lynette, another question. Are you analysing data of those who start the process, then drop out or renege to find out where they are coming from, to identify other potential areas to potentially locate services or consider alternative service models?
Yeah, that another really good question. No, I haven't looked at that. Sometimes it's interesting. We have had people, when the clinician has said to the patient, we're really considering you for an IDAT admission, sometimes that's the catalyst for that person to think, okay, this is really serious. I don't want to be locked up in in Orange or in Sydney. I'm going to do something voluntary. And sometimes those people actually go in and to a mainstream long-term rehab program. But no, I haven't started to look at that area of research. It's interesting, since I first started my research, I've actually started to add all these different little research projects that I could start doing. It's opened up a whole can of worms.
Yeah.
Thanks, Scott.
Is there the ability to have mentoring from community and support for youth to senior people in community to guide in culturally appropriate ways?
Yeah, that's a really good point as well. I think we're very fortunate here in Orange that we actually have an Aboriginal mental health worker that will often come into our unit to support us to ensure cultural safety of the person. We can access our local AMS, which is good. So even the other day when we had NAIDOC Week, our Aboriginal clients were able to go and participate in NAIDOC Week. Which was great. So we do try and engage our other Aboriginal workers to support our clients.
Yeah. Also, another question is, do you hear back from people after they've left the IDAP unit or about how they go?
We do. It's interesting that although we're a involuntary program to start with, and when someone leaves we set them up with their services back out into the community, but we offer a 6-month follow-up. So I get on the phone and I'll ring up someone and say, you're happy to take my call, how's everything going, what are you up to? And a lot of the patients stay engaged with us. So even though they were involuntary at the beginning, they didn't like being in with us, but we're actually seeing a change when they go back out into the community, because they see that we are here, we're not judging them, we're here to support them. I had someone not so long ago say to me, Lynette, he rang me because he hadn't heard from me for 2 weeks, and he said, I'm just ringing to see if you're okay. And I had to have a bit of a cackle because I thought, hold on, isn't it supposed to be the other way around? So Scott, we do have a good connection with our patients. Sometimes the services will contact us and say, the patient that was here with you so many months ago or last year, that person still remained sober and substance free. And that's what it's all about. It's about them being able to take control of their life again. Whereas for so long, for many of our patients, the drugs and alcohol have controlled their life. So what we're wanting to do is to take that and give them the strength to take control of their own life. So we do hear back a lot of great stories. People will send me photos of their babies. One person sent us a photo of her in her wedding dress. So it was really wonderful. So we do get lots of feedback.
Yeah, just 2 more questions and then we'll close or finish. Thanks. Do you develop resources to feedback information that may be used as a positive feedback loop and motivate people?
We've just created a new discharge booklet that we're giving every patient that leaves our service. It's got lots and lots of information, where to access services, our phone numbers, journals that they can write, how they're going. So we are trying to do that. We also provide comprehensive assessment reports from our allied health team to the clinicians out there in the community, as well as a medical detox summary. So that's outlining what we've done in the unit, what our recommendations are, and also how to perhaps work with that individual back out in the community. So it might be, if there's cognitive impairment, it might be saying, look, when you're seeing this patient, maybe the use of a diary so that you write their appointment time next for next week in their diary so that they've got it. So we try and do those little things to help.
Yeah. Given that there are so few beds in the program overall, is it difficult for potential participants to get in? How's that managed? And although the program is involuntary, I guess that participants would have to be quite motivated to be able to get into the LDAP program.
Yes, we have our work, we've got two nurse consultants who manage our waiting list. So one here in Orange and in our sister unit at Herbert Street. So they're in constant communication with each other. So what they may do is say, hey, we've got a bed coming up next week. And, you know, have you got anyone that's really quite serious or really unwell that you need to get into a bed? So we might bring that person in. So we manage our waiting list. We will give priority to a woman who's perhaps pregnant and actively using harmfully for both her and her unborn child. So, you know, we do manage our waiting list that way. A lot of the people may go underground when they know that they're on the list. So it might take a while to try and locate them to then come into to a service to do the initial assessment to bring them in here. But once the dependency certificate has been written, they then need to come straight to IDAT via a hospital.
Yeah. Final question. Basically, it's so great, Lynette, thus follow up over the telephone. This is different from the clinical model, and why do you believe it might not be used all over health?
I'm not quite sure. I think for me, I want to be proactive. I want to keep calling people. So I might have someone that you know, if I don't hear from them or I make contact or try to make contact 3 or 4 times, often in mainstream, they're taken off the books. I keep trying because one day that person may just pick up that phone and say, hey, Lynette, it's great to hear from you. So for that 6 months, I will continue to be actively seeking them out unless they say to me, Lynette, we don't want to hear from you anymore. We've had enough of your phone calls.
Yeah, right.
Yeah.
Okay, well, look, thanks a lot. And obviously, because I could see all the different questions that were coming through, there's a lot of people were basically saying that for yourself and Liz, that what amazing work you're doing. And obviously there was a lot from rural New South Wales supporters out there from Dubbo and places like that who were saying that you know, it's amazing and keep up the great work. Which obviously we all love to hear, right? But usually we don't. But anyway, look, it's been amazing. I'll give you basically, if you want to, basically a minute to do any final comments.
So, Scott, my take-home message is that although involuntary drug and alcohol treatment is seen as controversial, I'm seeing noticeable improvements in our people coming into treatment. I'm hoping that the support from New South Wales Ministry of Health and the CRE, who've been unbelievable supportive, to be able to continue to explore this topic and ask our Aboriginal people who come into IDAT to say, was the admission justified? And then to look at their responses so that we can explore further ways to ensure cultural safety in a supportive and a beneficial environment for all. And it's interesting, Scott, only yesterday I rang one of my outreach patients and I said to her, you know, you've been clean now for several months, and was your time here in IDAT justified? And her response was 100%. it was just what I needed. But I didn't know that at the time. And that's often the case. They didn't know prior to coming in or within that first week. So watch this space. Thanks, Scott.
Look, like I said, thanks a lot, Lynette. I suppose in wrapping up, it's been a great presentation from both yourself and Liz. Clearly, you know, groundbreaking. I didn't realise until I heard Liz that, you know, this is the first research of its kind, looking at Indigenous Australians and what role, if any, mutual support groups such as Smart Recovery and those sort of things do play in the drug and alcohol area. Obviously, listening to yourself, I knew that the Northern Territory had involuntary treatment. I wasn't really aware of New South Wales. And yeah, you're right. I get people ringing me quite often, and they tend to be mum and dad of somebody who's got a problem, who might be, in their opinion, on the verge. The only way that they can see that that person might stop using and save their life is if, you know, what you was describing, involuntary treatment. And yeah, we just don't have those sort of systems elsewhere. I can see that there is a need. I'll be honest, I always thought it was, you know, up to the person to sort of want to change, but clearly there are people out there that are so dysfunctional that programs that you've looked at and researched are well needed. So again, like I said, thanks a lot for the research that you've been conducting, but also that Liz. And I suppose we've really been, I've been really enjoyed being part of this 2020 research symposium series that the Centre for Research Excellence in Indigenous Health and Alcohol have been managed to pull off. Due to COVID-19, we would have had more of a face-to-face, but doing it via this sort of medium for a lot of us is new, but I think it's been excellent. Anybody that is interested, a recording of today's symposium will be placed on the CRE's website, www.gathering.edu.au, in the next couple of days. We obviously will continue, so keep your eye out for the 2021 series next year. I'd like to thank, obviously, before we do close, Talila Reynolds, Anna Stern, Michael Doyle, Tegan Weatherall, Gemma Corder, Liz Dahl and Lynette, who've been the researchers and the students, by the way, through the Centre for Research Excellence in Indigenous Health and Alcohol. It's been a great journey. I hope that people out there that have sort of linked in or joined in, based on the comments that I've seen, people obviously quite enjoyed hearing from, in particular, let's be honest, this is the first time that we've had Indigenous researchers talking about Indigenous research that they've been conducted, and I wish you well in the future. And, you know, look forward to your graduation. Take care and thanks a lot.